Here we go.
Okay, thanks. Okay. Welcome to our review of carotid stents and the nursing care associated with this intervention. We're going to cover a lot of content in a short period of time, but don't worry, this presentation is being recorded and will be available to you. No, okay. There we go. Okay, so part of what we wanted to participate in is we'd like to acknowledge that we're gathered today at the traditional meeting place and home for many Indigenous peoples, including the Blackfoot, Stoney Nakoda, Tsuut'ina, Piikani, Cree, Dene, Inuit, and Métis peoples as identified in Treaty 7 and the Métis Region 3 territory. We respect the treaties that were made in these territories. We acknowledge the harms and mistakes of the past, and we dedicate ourselves to moving forward in partnership with Indigenous communities in a spirit of reconciliation and collaboration.
So throughout this presentation, we've used the Canadian Stroke Best Practice recommendations to inform the content. We will review the background of symptomatic carotid artery disease, and I apologize if I say coronary, I don't know why I have a slip between the two today, or CAD, we'll just use that term for short. We'll discuss key principles of nursing care, share 3 separate composite case examples, and it's important to note that these are fictitious patients, but based on common patient scenarios that you might see in practice. We also want to acknowledge that due to the nature of this population, some of the situations or outcomes that we discuss today may be sad. We will end with key takeaways and a summary of practice.
So carotid artery disease can be either asymptomatic or symptomatic. Today we're going to discuss symptomatic CAD. So atherosclerotic CAD is linked to about 20 to 30% of all strokes. And typically we see ischemic events of a thrombotic nature at the site of stenosis, where the clot grows at the narrowed location in the artery, but emboli can travel from elsewhere, such as the heart or lungs, and get lodged in that narrowed spot. And this results in a lack of cerebral blood flow and perfusion.
Okay, so if you have an almost blocked carotid, how are these individuals still talking, walking, and functioning? When a major artery is partially blocked via autoregulation, the cardiovascular system diverts flow to the opposite carotid and vertebral basilar arteries to deliver blood to the brain. This is called collateral flow. A good analogy is an accident on a major urban highway, but there are still exits you can take to secondary highways to reach your end destination.
And then I have to click again, right? As you can see, the graphic on the left, we have a significant amount of narrowing due to plaque deposition and thrombosis, occluding the ICA. The shaded area is the vascular territory affected by this ischemic event. And in the image on the right, a high degree of stenosis, whoops, I went ahead too quick, sorry guys. A high degree of stenosis is indicated by the blue arrow on cerebral angiography. We want to emphasize that individuals presenting within 48 hours of acute stroke or TIA symptoms are at the highest risk of recurrent stroke and should be seen or transported from the community immediately to an emergency department with capacity for advanced stroke care.
So these at-risk individuals are often admitted to acute care for closer observation and evaluation for revascularization. So what do we care about as nurses? These are the key principles of care for secondary stroke prevention. Systolic blood pressure parameters are important to maintain cerebral perfusion. Due to the degree of arterial narrowing on the affected side, the brain tissue is already fragile, and any significant change in blood pressure can have severe consequences. Dual antiplatelet therapy, or DAPT, is now the standard of practice with diagnosis of symptomatic CAD. The risk of thrombosis formation or extension is still high on aspirin alone. Evidence shows that the DAPT regime has significant impact on decreased adverse neurological outcomes without an increase in bleeding. The most important takeaway for the care team, the patient, and their family is adherence to the DAPT regime daily. Even missing one dose can have serious consequences. Statins are prescribed for just about anybody with CAD. High-dose therapy is recommended for individuals with very high LDLs and individuals with suspected unstable plaque. Glycemic management. From an arterial disease perspective, is important to prevent any further inflammation. However, from a general stroke perspective, it's also important to get blood sugars within normal ranges as soon as possible to prevent expansion to the ischemic core. In addition to key principles of care, a solid neurovascular assessment pre and post intervention or procedure is vital to help identify any subtle changes in your patient.
Up until the last decade, endarterectomy or CEA was the go-to procedure. However, with advances in endovascular technology, the angioplasty and stent option has become an increasingly available and preferred option for both patients and clinicians. A less invasive approach, decreased need for general anesthetic, and faster recovery time are what the carotid angio and stent approach offers. So there's a quick visual here of both approaches demonstrating that endarterectomy is a procedure involving cutting open the neck and the carotid artery in order to remove the plaque. The endovascular approach offers both radial and femoral artery access sites, which is less invasive, generally has a quicker recovery time. Under letter A on the graphic on the right, you can see them deploying a filter through the stenos to ICA, and then in the under letter B, the balloon is inflated to squash the plaque against the vessel wall. And then under C, the stent is deployed and expanded to fill, and then in D, the arterial lumen is maintained patent. The Canadian Stroke Best Practice recommendations, I'm just going to scroll down, sorry, indicate consideration for revascularization starts at 50%. Occlusion for men, 70% for women. But in practice, if a patient has a moderate to severe stroke symptoms with occlusion measured slightly less than the indicated percentage, in practice, we do see carotid artery stents can still be considered as an option for revascularization, whereas CAA is likely not. In addition, according to Canadian Stroke Best Practice recommendations, most data regarding optimal timing of carotid revascularization for symptomatic carotid disease is from studies of endarterectomy and not stents. However, the best practice recommendations state that it may be reasonable to consider that similar recommendations regarding timing also apply to stents. Now we're going to talk about specific complications and what to watch for.
Okay, I know this is a busy slide, but these are a variety of complications post-stent. So the first and most often, most common, I should say, is the recurrence of TIA or stroke-like symptoms. These are often characterized by new or worsening focal neurodeficits, most noticeably changes in motor power, vision, speech, level of consciousness. So completing a comprehensive neuroassessment and notifying or activating a code stroke if necessary is a good first step. Bleeding. This includes internal or external bleeding at the puncture site. So it's often characterized by sharp throbbing pain, tenderness progressing to numbness, a cool extremity, and absent or weak pulses. The most important thing is to keep patients laying in bed flat, outline the borders, apply pressure if you need to, and notify the team. Hemodynamic changes can include vasovagal reaction, bradycardia, and hypotension. Patients can appear pale, cool, clammy, diaphoretic, and may have syncope or complain of dizziness, nausea, and/or vomiting. If IV fluids are ordered, start them as soon as possible and notify the team and activate a code as appropriate. Arterial complications can include a pseudoaneurysm, so that's a locally contained hematoma with turbulent flow, or an AV fistula, which is an abnormal connection between the artery and veins. Patients present with pain, numbness, or a weak or absent pulse and a cool limb. So observe for a pulsatile mass or a, sorry, I lost my place there, auscultate for a bruit, and keep the patient on flat bed rest and perform neurovascular assessments. Retroperitoneal bleeding presents as severe flank, back, or leg pain with visible bruising. Patients present with sudden onset of hypotension, tachycardia, and a rapid decline in hemoglobin. Notify the team and monitor neurovitals and vitals every 15 minutes. Cerebral reperfusion injury is also another complication, and we will cover this in details in later slides. Infection, so this may present as mild superficial infection at the puncture site or progress all the way to systemic inflammatory response and/or sepsis, likely requiring ICU care.
And now we'll move into going through our composite case examples. So this is Steve. He's a 64-year-old cisgender male. He's semi-retired engineer working less than 20 hours a week. He describes himself as overall healthy. However, he does have a history of hypertension and dyslipidemia. He presented to an ED department with reported TIA-like symptoms. So Steve's TIA event lasted 10 minutes with aphasia and right motor weakness. His initial CT head was negative. CTA showed stenosis of the left internal carotid artery, and follow-up Dopplers revealed a 75% stenosed left ICA. In terms of medications, he was loaded with aspirin and Plavix, and then started on a dual antiplatelet regime of aspirin 81 milligrams and Plavix 75. He was also on Lipitor and Norvasc. He refused an open endarterectomy procedure, didn't want a big neck incision or have an extended recovery time because he was still working, and opted to have a stent placed 7 days later. So he had an endovascularly placed carotid artery stent, radial approach, and the nursing care, oh, come on. I lost my cursor, there we go. Apologies. The nursing care that he received post was he recovered in 2 hours in the recovery unit or PACU. He had radial compression band placed for that radial approach, and so that required the neuros and the deflation sequence Q15 minutes for an hour until that was deflated. Then he was returned to the inpatient unit. He was monitored every 2 hours for another 2 times for a total of 4 hours, and then every 4 hours for the remainder of his stay. So Steve's vital signs stayed stable. He had no neurological changes, no complications with his puncture site overnight. So he got discharged the next day. And the teaching emphasis that was provided to him was around, he had some lifting restrictions with that left arm where the puncture site was, no heavy lifting with that left arm for 24 hours. In follow-up care, he was seen by a stroke prevention clinic, neurovascular clinic in 3 months, and he had follow-up imaging before he attended and got to go home.
Okay, so here is Bob. Bob is an 82-year-old cisgender male. He retired 10 years ago from a long career as a corporate executive. His past medical history includes many vascular risk factors. So he's a former smoker, continued daily alcohol use, he has high blood pressure, dyslipidemia, he's a type 2 diabetic, he has AFib, he's currently on apixaban, and he has a sedentary lifestyle. So Bob presented with a right ICA and MCA M1 tandem occlusion. His symptoms included left arm and leg weakness, left-sided facial droop, and dysarthria. He received endovascular thrombectomy and had successful recanalization of his M1 occlusion. 24 hours after his intervention, EVT, his CT was clear of hemorrhage, and the team started him back on his home dose of apixaban. He was admitted to the acute inpatient stroke unit for neurosurgical evaluation for carotid revascularization, and they recommended doing a stent in 5 days' time. So in the interim, the stroke team placed the following orders: neurovitals and vitals every 4 hours, very strict blood pressure parameters to keep his systolic blood pressure between 160 to 180, adequate glycemic management, so wanting to keep his blood sugars between 4 and 7, and adequate hydration status. So his apixaban was held before going for the stent procedure, and he had no interprocedural complications in the IR suite. However, once he got back to the acute stroke unit, approximately 6 hours after his intervention, his blood pressure dropped, he became bradycardic, he had new onset of left-sided hemiplegia with severe confusion and restlessness. So the team notified, the nurses notified the stroke team right away. He went for a stat CT CTA, which demonstrated that his stent had completely reoccluded and thrombosed. He returned to the IR suite for replacement of the stent, and then he was stabilized and transferred to the neuro ICU for another 3 days. Bob had a prolonged recovery on the acute stroke unit. He received inpatient stroke rehab for 2 months and then was discharged home with early supported discharge.
This is Carol. She's a 75-year-old cisgender female. She's a retired school teacher, lives alone. She has a past medical history of chronic kidney disease and hypertension. Unfortunately, it was approximately 28 hours before anyone found her after her stroke, so she presented outside the window for any acute treatment. Her symptoms included aphasia, visual field deficits, right hemiparesis, and extinction on the right. So Carol's results from imaging revealed that she did have atherosclerotic stenosis in her left common carotid artery extending into the left internal carotid artery. The CT perfusion showed delayed filling in her left MCA and ACA, and the CT angio showed high degree of occlusion. This was confirmed again with carotid Dopplers and 93% stenosis. She was started on dual antiplatelet therapy and assessed by the neurovascular team. The stroke team ordered systolic goals of 170 to 190 to maintain perfusion. It was determined she was not a candidate by the neuroendovascular team for endarterectomy. However, it was booked for a stent the next day. After her procedure, she developed mild bleeding at the radial site, and the radial band had to be reinflated to achieve hemostasis. She recovered in PACU for 3 hours. She returned to the inpatient unit. 11 hours later, she developed severe headache, decreased LOC, worsening right hemiparesis, and oral automatisms, lip smacking. She had a systolic blood pressure that was fluctuating between 205 and 225. And the nursing team activated a code stroke. She was accompanied to CT, and imaging showed a large area of hemorrhage. There we go. Her out-of-town family were called, and the medical team discussed goals of care. So it was decided to engage the palliative care team and change her goals to comfort care.
Okay, so as you heard in Carol's case example, if you have a bleeding complication at the site, the goal is to reestablish hemostasis. So at a puncture site, hold 2 to 3 fingers above the site until hemostasis is achieved. And for a radial compression device, so there's 2 examples there on the screen, reinflate the balloon or band to achieve patent hemostasis.
Carol also had a significant cerebral reperfusion injury. So cerebral hyperperfusion syndrome can present on a spectrum of mild to severe symptoms, commonly associated with an increase in systolic pressure. It's also described as a clinical constellation of symptoms, but we typically see severe headache on the side of reperfusion, eye and facial pain, focal neurological deficits, possible intracranial hemorrhage, seizures or encephalopathy, and loss of consciousness. We can see an event much like Carol's stroke on the series of images here. So first on CT, where we can see the hypodensity of the infarcted area is circled, moving to the CT angio highlighting the vessels, and also on MRI. The last image is a CT perfusion scan, and it reveals the bright red hyperperfused brain tissue in the area immediately surrounding the infarcted brain tissue. So the incidence of cerebral hyperperfusion syndrome peaks at about 12 hours post-stent procedure. So we must be most vigilant, knowing this is the prime window for when we see signs of clinical deterioration. Our nursing assessments and monitoring of the patient is crucial during this time period. The infographic on the right demonstrates the work of Gonzalez, Garcia, and et al., and their findings of the population most at risk for the cerebral hyperperfusion syndrome, which fits Carol to a T.
Okay, so in summary, prevention of CAD is our goal, but we must treat symptomatic CAD. We have seen an increase in carotid stents as a viable alternative to CEA over the past decade. However, it's still a balance of provider and patient preference and surgical risk factors to determine which approach is more suitable. Complications do happen, but an excellent baseline neuro assessment pre and post procedure and neurovascular assessment will help you to identify early changes in your patients. We also wanted to share a key takeaway message from one of our physicians, Dr. Mohammed Al-Maklafi. So he's a stroke neurologist and neurointerventional radiologist at the Calgary Stroke Program. So this is in his words. I can't stress enough the importance of reminding patients to stay on dual antiplatelet therapy. I see stent thrombosis or occlusion in clinical practice among patients who discontinued antiplatelets prematurely or due to a lack of prescription. If nurses can ensure that patients are well informed and that their discharge prescription is for 3 months, that would be superb.
So we want to say thank you to CAN, the scientific committee, for having us come present, and thanks to Dr. Mohammed Al-Maklafi for his clinical insights and some presentation resources, primarily some of the imaging pictures.